speaker, Dr. Pranita Tamma. Dr. Tamma is an associate professor of pediatrics and the director of the antimicrobial stewardship program at Johns Hopkins University School of Medicine. She is also an international leader in diagnosing and treating patients with gram-negative infections and is an authority in the field. I can say that very comfortably now after she got bombarded by many emails from me throughout the years. So her highly cited work changed longstanding practices basically around beta-lactam therapy, and her more than 250 peer-reviewed articles have significantly advanced the field of antimicrobial resistance. She serves as the lead author of the IDSA guidance on the treatment of antimicrobial resistant gram-negative infections, which truly has become an essential guidance for us here at Phoenix Children's and to other infectious diseases physicians around the world on the management of multidrug-resistant gram-negative bacteria. She's also an editor at Antimicrobial Agents and Chemotherapy, all while treating children with infectious diseases, mentoring junior faculty, fellows, residents, and medical students, but also answering, as I said, my emails and other ID physicians' emails seeking advice for management of difficult to treat infections. Her achievement has actually been recently recognized as she was named the recipient of the 2024 Oswald Avery Award for Early Achievement. The award recognizes outstanding achievements in an area of infectious diseases by the Infectious Diseases Society of America member or a fellow who is 45 or younger. Dr. Tamma will be presenting a case-based discussion around the treatment of multidrug-resistant infections in children. And without further ado, Dr. Tamma.
Thank you so much. Thank you for that really kind introduction, Wasim. I'm excited to speak to all of you today. I'm sorry I couldn't be there in person. And I'll start off by saying I have no disclosures, and I will be speaking about a lot of newer drugs. So hopefully you'll believe me when I say this is my unbiased view. And I thought I would focus on extended spectrum beta-lactamase producing Enterobacterales, or ESBL producing infections, Stenotrophomonas, which we often forget is a pretty drug-resistant bacteria, and Pseudomonas aeruginosa. And just to sort of frame the issue before we dive into clinical cases and talk through treatment approaches, I think it's important for all of us to kind of step back and think about what a big issue antimicrobial resistance is worldwide. It's expected by 2050, more patients will die from an antimicrobial resistance infection than from all of these other causes combined, including all malignancies, which is really impressive. And I think what's really concerning is that in some of the resource limited areas in the world, Africa, Asia, Latin America, there's disproportionate numbers of people dying from AMR infections. And unfortunately, access to newer drugs in these areas is also very limited. So I do think there's a lot of disparities around AMR. And even some of the newest drugs we have, when they do eventually become generic and more affordable to some of these more resource-limited countries, by then we anticipate that the bacteria will have outsmarted these newer drugs, and we will see they will not be as effective as they might be at the current time. So let's go ahead and start with ESBL-producing infections. I'll start with a case and then we'll kind of give an overview of these infections. So this is an 18-year-old female. She had a renal transplant secondary to focal segmental glomerulosclerosis, and she's had multiple urinary tract infections in the past, including one within a month. She's now presenting with dysuria, fevers, rigors, hypotension. Her urine and blood cultures are growing E. coli, and she has a pretty large renal abscess as well. And she's transferred to the ICU to initiate vasopressors. So we'll come back to this case in a little while, but I just wanted to show you the susceptibility report for the E. coli recovered from her blood. You could see that the ceftriaxone is MIC is 32, which is very high. Usually we say 1 or less is considered susceptible. And there are a few other scattered S's, which we'll talk about in upcoming slides. And I just wanted to highlight that cefepime is what we call susceptible dose dependent. It used to be what we often thought about as intermediate. So if you give a high enough dose that it might be effective, that's what intermediate or susceptible dose dependent generally means. It's susceptible to carbapenems like ertapenem, meropenem, and susceptible to piperacillin, tazobactam, commonly referred to as Zosyn. Okay. So let's talk a little bit about what we mean by ESBLs. So ESBLs are enzymes produced by certain bacteria, certain gram-negative bacteria, and these enzymes can generally inactivate penicillins, cephalosporins, and aztreonam. And sometimes in vitro, we may not see that an isolate producing an ESBL might look susceptible to some of these drugs, like in our patient's case, Piptazo. But the concern is that clinically, these enzymes will be able to inactivate these beta-lactam agents. They don't inactivate non-beta-lactam agents like aminoglycosides, trimethoprim sulfamethoxazole, or fluoroquinolones like ciprofloxacin or doxycycline. So there's several non-beta-lactams that should still be effective against bacteria that produce ESBL enzymes. But the problem is ESBL genes are generally carried on plasmids, which like to spread from bacteria to bacteria. And these plasmids often have resistance determinants to other antibiotics like aminoglycosides, trimsulfa, ciprofloxacin, doxycycline. So we often are left with very few treatment options, and notably carbapenems being the treatment that often is left as the agent that is likely to be active. So a few other notes about ESBL. So these enzymes are most commonly produced by E. coli, Klebsiella pneumonia, Klebsiella oxytoca, and Proteus mirabilis, but by far it's really E. coli, Klebsiella pneumonia. And about 5% of other Enterobacteriales produce ESBL enzymes. And this is good news because, when we see a ceftriaxone-resistant E. coli or Klebpneumo, even if your lab or the patient's transferred from another hospital where there's no specific testing to tell you, is this isolate producing an ESBL or not? If you have an E. coli or a Klebpneumo, if you see that it's ceftriaxone resistant, there's a very high likelihood, over 90%, probably about 95%, that this bacteria is producing an ESBL enzyme. And fortunately, if you see a bacteria like Enterobacter cloacae, Citrobacter frundii, Serratia marcescens, even if those isolates are ceftriaxone resistant, it's highly unlikely that they're producing ESBL enzymes. I do also just want to mention, and this is basically what I just said. Right now, there's not any sort of criteria for labs in the United States to perform ESBL testing on isolates. Some labs choose to do so, but it's not a sort of a widespread rule that they have to do so. And many of our labs might do it for blood cultures. With these multiplex panels like Verigene, BioFire, something called the GenMark ePlex, where you might see that there's an ESBL being produced from an organism growing in the blood. But often laboratories don't do it for other sources of infection, like urine, for example, where E. coli causes 90% of UTIs. And is an organism where we might think about ESBLs. The last thing I'll mention is that if you do use a test like the BioFire or the Verigene in your microlab, you might see the word CTXM, which is a type of ESBL. These are the most common ESBL enzymes, but they're really not the only ones. About 10% of ESBLs are not CTXMs. The reason I bring this up is just to let you know that there's a lot of other ESBL families, and even though ESBLs are a lot more common than carbapenemases, we do have ways to distinguish a KPC, an NDM, and I understand Arizona seems to be a hotspot for NDM producing enzymes, which stand for New Delhi metallobeta-lactamase enzymes in the United States. And we know from our carbapenemase experience that depending on the type of carbapenemase, there is one treatment that'll work for one enzyme and not the other. Considering how common ESBLs are, We really are in our infancy in understanding which drugs may or may not be effective against the different types of ESBLs. But again, I think just stepping back, what I'd like you to kind of keep in mind from this slide is that ESBLs inactivate beta-lactams, but not carbapenems. There's always rare exceptions, but I would say not carbapenems. You should think of them when you see an E. coli, Klebpneumo specifically, where the ceftriaxone where the isolate is not susceptible to ceftriaxone, and less commonly so, but also maybe a concern in Klebsiella oxytoca and Proteus mirabilis. Okay, so let's kind of move on a little bit to, so if you recall our patient's case, her isolate was susceptible to piperacillin tazobactam. So questions have come up in the infectious diseases community about is piperacillin tazobactam effective against bacteria producing ESBL enzymes? And just to orient you, piperacillin is a beta-lactam drug. Tazobactam is what we call a beta-lactamase inhibitor. So whenever we give beta-lactam, beta-lactamases, they're basically two separate molecules. The point of the tazobactam here is to find the ESBL enzyme, because this is an inhibitor, to bind to it, to inhibit it, so that piperacillin can make its way to the penicillin binding protein target that it has the greatest affinity for. But early on, when ESBL started to become a problem clinically in the early 2000s, we started to see in vitro data such as this. And just to orient you, the y-axis here is bacterial growth, the x-axis is time, and this is what we would call low inoculum ESBL infection. So this might mean 10 to the fifth of bacteria or less. For us as clinicians, this means something like a urinary tract infection, biliary infection, something where patients often get better very quickly once the right antibiotic is started because there's not a ton of bacteria there. You could see when there's no bacteria that the organism grew very nicely. So this is an E. coli. It's producing some ESBL enzyme, but again, there's no antibiotic, so we expect the bacteria to grow. But in the setting of cefepime, piptazo, meropenem, so all of these beta-lactam drugs, they were all actually able to reduce the growth of the bacteria quite nicely. So that's great. The problem, what was seen in studies like this, and there have been several like this, is that when there was a high inoculum, so this is defined as 10 to the 7th or more of bacteria, this might include a bacteremia, a pneumonia, an intra-abdominal collection. What would happen is that the meropenem was still able to limit the growth of this E. coli, but that didn't seem to be the case for cefepime, piperacillin, tazobactam, and of course, no antibiotic, suggesting that when there's a lot of these enzymes produced, these ESBL enzymes, they are able to successfully hydrolyze drugs like cefepime or piptazo, even if in vitro on your susceptibility report, it looks like these drugs should be active. So just a couple of concerns about tazobactam as an inhibitor, and this might be a little nuanced for an infectious disease audience, but please bear with me. As I mentioned, there are several types of ESBL enzymes. Right now, about 90% are CTXMs, but in the early 90s, starting in the 1980s, the 90s, early 2000s, there were other ESBL enzymes that dominated, something called SHIV and TEM ESBL enzymes. Piperacillin tazobactam was developed in the 90s, and it was really the tazobactam was meant to inhibit these other ESBLs, not the CTXMs that we see today. So as an inhibitor itself, it really just wasn't designed for the ESBL epidemic that we're currently experiencing. I will mention there's a cousin of tazobactam called N-metazobactam. So it's an FDA-approved antibiotic, cefepime N-metazobactam. And this inhibitor, beta-lactamase inhibitor, appears to be much more efficient at inhibiting these CTXM enzymes. So unfortunately, I don't know a single hospital in the country that stocks cefepime and metazobactam, but I do think that this drug is from what we know, does seem to be a very effective drug against ESBLs, much better than piperacillin tazobactam. Okay, So the other main issue was that what we see with tazobactam as a beta-lactamase inhibitor is that when there's so if there's a plasmid with an ESBL gene, there's multiple gene copies, so there's more ESBL enzyme being made. There's various types of ESBL enzymes being made, so maybe a CTXM plus one of these SHIV enzymes. There's other beta lactamases that are not ESBLs. Basically, whenever we see a lot more enzyme production, beta lactamase enzyme production, we do see that tazobactam's effectiveness really does seem to diminish quite rapidly. And I will point out that you might be familiar with the drug ceftolozane tazobactam. This is a drug that became available around 2014 or 15. This is a good anti-pseudomonal drug, and it uses the inhibitor tazobactam, just like piperacillin tazobactam. But compared to ceftolozane tazobactam, where the beta-lactam to inhibitor ratio is 2-to-1, so there's a lot more inhibitor around to protect the beta-lactam from hydrolysis. For pip-tazo, there was very little tazobactam included in the formulation. Which might also explain it's just not enough enzyme to find the ESBL enzymes, not enough beta-lactamase inhibitor to find the ESBL enzymes and inhibit their activity. And then the final point I'll just make about why tazobactam might not be as effective as we'd like. For older drugs like pip-tazo, the breakpoints were established predominantly on the beta-lactam piperacillin. We basically ignored the tazobactam, the same with ampicillin, sulbactam, etc. Compared to newer drugs where we look at the kinetics of both the beta-lactam and the inhibitor. So an example of ceftolozane tazobactam or ceftazidime avibactam. The reason this is important is you want both the beta-lactam and its partner beta-lactamase inhibitor to have matching kinetics, right? If the inhibitor gets eliminated from the body very, very quickly, has a super short half-life, and the beta-lactam does not, it's basically left hanging by itself, right? With no inhibitor to find those ESBLs, bind to them, and inhibit them. Okay, so that's a little bit of the theoretical background about why pip-tazo may not be a great drug for ESBLs. Let's move on to some clinical data. Some of you might have heard of this trial. It's commonly referred to as the Merino trial, and it's a randomized clinical trial comparing piperacillin tazobactam to meropenem for ESBL-producing bloodstream infections. And I'd say that this is probably the most well-known infectious disease trial that's been published. And basically, what these investigators did is if a patient had E. coli or Klebpneumo identified in a blood culture by their local laboratory standards, and it was not susceptible to ceftriaxone. So again, if you see E. coli Klebsiella not susceptible to ceftriaxone, there's a high likelihood it's an ESBL producer, but the isolate had to be susceptible to both pip-tazo and meropenem. And then patients were randomized to meropenem or pip-tazo. And I'll just go to sort of skip ahead to the results here, but they were quite striking. The y-axis is mortality, x-axis is time, and you could see that in pip-tazo, mortality was significantly higher than meropenem. And they basically, and they did for most of these isolates confirm that they truly did have an ESBL enzyme. And you know, I'll note that, so the reason they terminated early is they realized even if all subsequent patients randomized to meropenem did not survive up to day 30, pip-tazo would have still been statistically significantly worse. So this is the trial that sort of established the idea that carbapenems, so whether it's ertapenem, meropenem, imipenem, are the treatment of choice of ESBL-producing infections. Sorry, I'm just going to check the time. Make sure we have enough time. Okay. And I just want to also point out that there were various subgroups looked at. Pit bacteremia score, which is a marker of how sick patients are. 4 or more means they're very, very sick. E. coli versus Klebsiella, urinary source, non-urinary source, immunocompromised, not an immunocompromised. And this is what we call a forest plot. The dotted vertical line, if something crosses it, it's not significant. But you could see here for these subgroups that even if not statistically significant, all the subgroups really did seem to favor meropenem as treatment for these ESBL-producing infections. I'm going to skip this slide just because I want to make sure we get through everything else. The only point I want to make here is they did retest the MICs for Piptazo using what we call broth microdilution, which is a reference method for antibiotic susceptibility testing. And even though mortality was not statistically significantly different anymore, because they did not have all available isolates to test, so the sample size decreased, just numerically, it is still concerning that mortality was higher in the piperacillin tazobactam group. Okay, so this is all meant to say what I discussed so far, that unfortunately Piptazo might appear susceptible on your susceptibility report for an ESBL producer. And again, if you don't know it's ESBL producing, if you have an E. coli, Klebsiella pneumonia that's not susceptible to ceftriaxone, that's when you should think about ESBL production. Piptazo, even with if susceptible, may not be an optimal agent. And the IDSA guidance suggests that if you have an invasive ESBL producing infection, that you really should not be using Piptazo. I will say that for cystitis, so this is sort of lower urinary tract infection. Generally, we see it in otherwise healthy young women without fevers, or even if they had pyelonephritis but not terribly sick, and maybe someone started Piptazo and now they're improving. There might be times like that where it might be reasonable to finish off on Piptazo. I don't think we have enough evidence to say that's not okay. But whenever we're talking about somebody who has systemic illness, the preference still would be to give a carbapenem at least initially. Very briefly for cefepime, because if you recall, this patient, the patient we spoke about initially, the young woman with urosepsis, her ESBL producing E. coli was in this what we call susceptible dose-dependent or intermediate range to cefepime, and occasionally we see, or not more than occasionally, about 20% of the time, ESBL producing infections are susceptible to cefepime. But basically, if you recall that those time kill curves where we were looking at the low inoculum, high inoculum, recall just like Piptazo, cefepime was able to be hydrolyzed when there was a lot of ESBL enzyme. There's a lot of the similar concerns with Piptazo. Cefepime does not have a beta-lactamase inhibitor to help it out, which makes its situation probably even worse. And even though we don't have clinical trials comparing cefepime and carbapenems for ESBL producing bloodstream infections the way we did with that Marino trial I presented, when you look across observational studies, this first study is actually a subgroup analysis of a trial. But basically, what's in red here is that studies where the outcomes appear generally worse in the arm where the patients were receiving cefepime. So the thought is, with what we know in vitro about cefepime being likely to be hydrolyzed by ESBL enzymes, and our observational data suggesting that there's a signal that maybe cefepime is not as good of a treatment for ESBL-producing bloodstream infections. It's generally not favored. And I do want to mention there was this very nice trial from South Korea looking at patients with ESBL-producing pyelonephritis, are what we call complicated UTI. And this is UTI in patients with nephrostomy tubes, stents, renal transplants, something where the anatomy basically is not normal or there's some urinary stasis. And I didn't, but basically what I wanted to point out here, there was a cefepime arm. The cefepime MICs were all quite low, 1 to 2, and they actually had molecular confirmation that these isolates produced an ESBL. But clinical failure was so high in the cefepime arm, they had to terminate it early. So again, this is all meant to say you might see cefepime, you might see Piptazo as options on susceptibility reports, but if you have an E. coli where you see that the ceftriaxone MIC is not in the susceptible range, it's probably not a great idea to be considering these drugs. I do want to mention this particular patient's isolate was susceptible to trimsulfa, not to Cipro. And again, the point here is that because beta-lactam ESBL enzymes do not hydrolyze drugs like trimsulfa, Cipro, if the isolate is susceptible to these drugs, once the patient shows some clinical improvement with a carbapenem, there's really no reason you can't transition the patient to a drug like oral Trimsulfa or oral ciprofloxacin. You don't necessarily have to keep them on a carbapenem for the entire treatment. Okay, so take-home points for ESBLs. Again, I believe that the preclinical clinical data really do support the use of carbapenems for ESBL infections. I would say at least initially. Like I said, piptazo, maybe it's reasonable for urinary sources of infection if the patient's not very ill appearing. There are some observational studies that suggest this. There's actually no observational studies that suggest poorer outcomes with patients with urinary infections caused by ESBLs that received piptazo versus carbapenem. There is the way there is with bloodstream infections. I still hesitate if you're talking about somebody terribly ill or where there may be a nidus of infection that's residual, where there might be a fair amount of ESBL enzyme being produced. But just something to keep in mind. And I do believe we have enough data to say we really shouldn't be using cefepime for these infections. And then again, if an isolate is susceptible to non-beta-lactam agents, depending on the source of infection. If the drug gets in fine, there's really no reason we can't transition to these other agents. Okay, I'm going to move on to Stenotrophomonas. And then depending on time, I was hoping to talk about Pseudomonas, but if we run out of time and if I'll ask Wasim what he thinks. If it's better, we just stop and take questions. We can do that. Okay. So Stenotrophomonas. So this is a patient we took care of at Hopkins last year. And our pharmacist, infectious disease pharmacist, wrote this up as a case report. This was a 1-month-old baby with a congenital cardiac disease called transposition of the great arteries. The baby underwent the traditional arterial switch operation on day 5, went on to ECMO post-operatively, which unfortunately is not something we expect to happen. And it eventually needed to be listed for a cardiac transplant. So the baby is, as you could see down here, beginning on day 30, had positive cultures for Stenotrophomonas that persisted till day 37, despite the baby receiving trimethoprim sulfamethoxazole and lots of attempts to switch out lines and potential just sources of persistent infection. All these isolates were susceptible to Trimsulfa. It was even confirmed on the testing I said, broth microdilution, the reference approach to obtaining antibiotic MICs. So even though the Stenotrophomonas in this baby was susceptible to Trimsulfa, the baby remained persistently positive, blood cultures wise. Then the baby was switched to an antibiotic called cefiderocol, and you could see that the blood cultures actually cleared quite quickly. And this patient went on to do very well. So many of you probably know Stenotrophomonas. It's something we probably see most in ICU patients, sometimes in our cystic fibrosis population. It's ubiquitous in water, sorry, it's a typo, in water environments. And it's known to produce biofilm virulence factors that might cause it to colonize or infect vulnerable hosts, such as those in the ICU. And it's always tricky to figure out, is this causing colonization or true infection, especially when it's recovered in the respiratory tract? One population where it can cause some serious mortality is in patients with hematologic malignancies like leukemia, where it can cause a very impressive hemorrhagic pneumonia or bacteremia with very high mortality. Okay, so let's talk about Stenotrophomonas. So treatment. So for many of us, we're used to, when we see Stenotrophomonas growing, we prescribe the drug trimethoprim sulfamethoxazole. But we're starting to realize that maybe this drug is not as effective as we used to think. It's unfortunately very difficult to tease out the clinical outcomes data for Trimsulfa against Stenotrophomonas. Part of this is because there's no clinical trials looking at Trimsulfa, so we're left resorting to observational studies. And there's a lot of selection bias with observational studies. There's issues where the sample sizes for many of the studies are quite small. The studies often compare respiratory infections, bacteremia, so there's a lot of heterogeneity, and we're not sure if this is colonization or infection. As you can imagine, just like the baby I mentioned, there's often delays in starting active therapy, right? We usually start drugs like cefepime or Petazo or maybe meropenem when someone first is presenting with fevers and signs of instability. And it often takes a few days before we recognize growth of stenotrophomonas and switch to a drug like Trimsulfa. So this is all meant to say the clinical data evaluating Trimsulfa for steno is not clear cut. So we're left deriving efficacy of Trimsulfa against stenotrophomonas from these in vitro models, so these pharmacokinetic, pharmacodynamic models and animal models. So I'll get to these in 2 slides, but I just wanted to point out one more thing. There's 3 groups internationally that are most well recognized for setting antibiotic breakpoints. So that tells us, is this drug active or not, likely to be active or not against this bacteria? And if something's susceptible, we assume that predicts in vivo clinical success. Usually for a breakpoint to be set, in animal data and in vitro models, we want to see at least 1 log kill of bacteria to say, okay, this antibiotic is likely to have some activity against this bacteria. So the FDA sets breakpoints. They establish breakpoints whenever a drug is FDA approved. So when Bactrim was first FDA approved, breakpoints should have been set for against steno, but they weren't, because they realized that the activity, in vitro activity, did not look good. So there's actually no indication on the package label for, I'm going to call it Bactrim, Trimsulfa, for Bactrim against stenotrophomonas, the way there is for E. coli and some other gram negatives. They reviewed these data in 2023, and they also decided that there wasn't enough data that gave them confidence that this drug, Trimsulfa, could cause at least a 1 log kill in stenotrophomonas. So again, no breakpoints. It's still not on the package label. The Clinical and Laboratory Standards Institute is a separate group. It's US based, but it has international members. It's used by large parts of the world. They re-reviewed data in 2023 also. There is a breakpoint. The breakpoint is 2 or less, and they decided to keep a breakpoint, but they said Trimsulfa has to be used as a component of combination therapy. And the reason was they didn't have confidence in the data they saw that Trimsulfa has activity to cause a 1 log kill against stenotrophomonas. I will say this vote was very contentious. Several of the voting members said we should remove the breakpoint. The problem was, for some of the drugs that probably are the most effective against stenotrophomonas, some of the newer drugs I'll talk about, including cefiderocol, which, if you recall, that's what the baby in the case was switched to, they're simply not available in many parts of the world where stenotrophomonas could be a problem, right? Like various parts of Asia, Latin America, Africa. And CLSI is a global organization. Lots of countries use breakpoints from CLSI. So they felt if they take Trimsulfa off the table, then there's not a lot left. UCAS, which sets breakpoints mostly in the European Union, does not have a susceptibility breakpoint of Trimsulfa against steno. They have intermediate or resistant, basically discouraging its use. So why are these groups hesitating to endorse Trimsulfa for stenotrophomonas? So I'll show you just one representative of preclinical data. So these are pharmacodynamic models where Trimsulfa was prescribed at a dose of 20 mg per kg per day. So that's a huge dose, right? In the peds world, we do maybe 5 to 10 mg per kg per day or so. This is a lot higher than we normally would give a patient. And to orient you again, these are time kill curves. The x-axis is time, y-axis is bacterial growth. These top 2 lines, the purple and black, are basically your controls. In green here is E. coli. And you can see when the trimethoprim MIC was 0.25, remember the breakpoint, the CLSI said is 2 or less. So a very susceptible organism. It's very susceptible. In green here is E. coli. I'll get exposed to a large amount of Trimsulfa. You see that there was more than a log kill in the E. coli, right? Several logs kill of E. coli there. Red is stenotrophomonas, and even with this low MIC and lots of trimethoprim sulfa exposure, Stenotrophomonas at best maybe had some stasis, but definitely did not have a one log kill. The same was true at an MIC of 1 and 2, which would again be considered susceptible. Really, Stenotrophomonas, just basically a straight line there. E. coli, you start to see as the MIC goes up, that maybe there's a little less of a kill, but there's still at least a one log kill. And then when you get to an isolate that's resistant to both, E. coli Stenotrophomonas resistant to trimsulfa, the MIC is 4, so above 2, you could see that there was not a log kill. So this kind of confirms this idea that trimsulfa seems to be able to reduce the growth of E. coli, but not Stenotrophomonas. And this has been repeated by multiple groups with the same results every time. In terms of one example of an animal study, this is a neutropenic rabbit model. These rabbits all had Stenotrophomonas pneumonia. In black means there were no antibiotic treatment for the rabbits. Blue means the rabbits were treated with trimsulfa. Green means they were treated with cefidrocol. And what you see here on the y-axis is survival. None of the rabbits that did not receive treatment survived. They all unfortunately died. I guess sadly they would have been euthanized regardless, even if they didn't so. But in terms of trimsulfa, only 25% of those rabbits survived, whereas almost 90% of the rabbits receiving the antibiotic cefidrocol, this is the rabbit that the baby I had described was transitioned to, survived. So basically, again, highlighting that we just don't have a lot of confidence in trimsulfa against Stenotrophomonas. So let's talk a little bit about this drug cefidrocol. What I want to point out here is this is another animal model looking at mice with pneumonia. And what they showed here is this, what the y-axis is showing something called time above the MIC. So basically, this is telling us how much of these, the beta-lactam antibiotic, in this case cefidrocol, do you need above the MIC of the bacteria to cause, basically, to be effective. In green here is Stenotrophomonas, in orange is Pseudomonas, purple is Acinetobacter. And basically what this suggests is you don't need a lot of cefidrocol to kill Stenotrophomonas. I think that would be the take-home point, I'd say. And it's actually quite astounding. There's never been a clinical Stenotrophomonas isolate anywhere in the world resistant to Stenotrophomonas. So much so that the CLSI has susceptibility-only breakpoints because there was no resistant isolates that they could find to even say what would be considered resistant, which I think is pretty remarkable. So basically, you know, cefidrocol is a newer drug. I believe it became available clinically in 2019. It is incredibly expensive. It is very broad spectrum. It covers NDM-producing Enterobacterales. It covers Pseudomonas, Acinetobacter. We won't get time to go into all of that today, but basically, it is a very broad spectrum drug. And again, it is very costly. So we would hate to overuse it unnecessarily. But I will say that if it was cheaper, I would personally think of it as my go-to drug when I thought a patient had a bad Stenotrophomonas infection. And I should say, I do think that way right now. But I think that it would probably be more commonly used for that indication if that was the case. And hopefully over time, that will be our go-to for Stenotrophomonas based on the data we have. Outside of case report data, we don't have any clinical trial data that really investigates the role of cefidrocol against Stenotrophomonas. So I should kind of give that caveat that many people would argue we have good animal data, preclinical data, but we don't have as much human data as we'd like to see, which I think is a very fair point. Okay, and again, I will wrap up Stenotrophomonas at the end. I do want to briefly mention the drug, and I should say drugs, ceftazidime, avibactam, estrianem. I would imagine that this is a combination of drugs that several of you have used since it sounds like in Arizona, there does seem to be quite a large number compared to many other parts of the United States of NDM, or New Delhi metallobeta-lactamase, producing Enterobacterales. I'll say that there is a drug called astrianem avibactam, which is available in Europe. In the United States, the drug company AbbVie did submit to the FDA requesting approval for this drug. So most likely this drug, aztreonam avibactam, will be available in the United States in 2025. So we won't have to use this combination of ceftaz-avi and aztreonam. That can be quite inconvenient because it's two drugs. They have to be given to the patient at the same time as extended infusions, etc. So let's talk a little bit about this. So Stenotrophomonas as a bacteria always produces two beta-lactamase enzymes. So remember we talk about ESBLs as a type of beta-lactamase enzyme? These are completely different beta-lactamase enzymes unique to Stenotrophomonas. One is called a metallo-beta-lactamase. So kind of like a cousin of the Nudeli metallo-beta-lactamase or the NDM. But this metallo-beta-lactamase is unique to Stenotrophomonas. All Stenotrophomonas produce it. The other enzyme is something called a cephalosporinase. It hydrolyzes several different beta-lactam antibiotics. So why might the drug, I'm just going to call it aztreonam avibactam, work against Stenotrophomonas? So the metallo-beta-lactamase enzymes, as you can probably know with your NDM experience, hydrolyze all beta-lactam antibiotics. Unfortunately, they don't hydrolyze the drug aztreonam. The reason is metallo-beta-lactamase enzymes have this very shallow groove, and all beta-lactams can sort of fit in that groove and get hydrolyzed by this enzyme. But aztreonam is a much smaller molecule, so even though it fits inside that groove, it doesn't make the right points of contact with the active site, so it basically evades hydrolysis. So that's great news for aztreonam. The problem is, if you're giving a patient aztreonam alone and they have Stenotrophomonas, the cephalosporinase enzyme will hydrolyze and inactivate the aztreonam. And so the way this drug works, like I said, the beta-lactamase inhibitor are two separate molecules. In this case, the avibactam is lower molecular weight. It diffuses through the bacteria much faster than the aztreonam. The avibactam goes and finds these cephalosporinases, binds to and inhibits it. So now the cephalosporinase is basically inactive. Now the aztreonam can slowly make its way through the bacteria. It doesn't have to worry about the cephalosporinase. The metallo-beta-lactamase is still hanging around, ready to hydrolyze it. But fortunately, again, aztreonam is not hydrolyzed by metallo-beta-lactamase, so it can still make it to its penicillin binding protein target. So aztreonam avibactam, just like sulfiterol, it does seem to have good preclinical data on its likely activity against Stenotrophomonas. Also, like sulfiterol, the clinical outcomes are pretty much limited to case reports. So I can say that we have large trial data telling us that this drug is a drug of choice for these infections. But from what we know about Stenotrophomonas and quite a few now reports of clinical success, aztreonam avibactam is likely to be an effective agent against Stenotrophomonas and currently considered a preferred agent by the Infectious Diseases Society of America guidance document. If you want to get a sense of susceptibility data across various cohorts, some of these are Stenotrophomonas isolates that are resistant to other drugs like Trimsulfa, some aren't. But overall, I would say that about 90% of Stenotrophomonas is susceptible to the drug aztreonam avibactam. So the take-home points for Stenotrophomonas is that, first of all, it's always important, of course, to try your best to differentiate infection, colonization. Do I need to treat or not? If you feel like this patient has had clinical changes that you could attribute to the bacteria and you want to treat, fine. I'll say that with Stenotrophomonas, just like ESBL producing infections, and really just like NDM producing infections, we don't have any evidence that these infections need to be treated longer than, for example, a susceptible E. coli. Often, for example, for bacteremia, we treat for about 7 days. I would say as long as you have 7 days of, quote, active antibiotic therapy, Stenotrophomonas does not need to be treated longer than these other organisms. Obviously, there's always case-by-case issues where Some patients, you might feel like they need to be treated a little longer because there's some clinical milestones they didn't achieve. But generally, just because a bacteria is, quote, antibiotic resistant doesn't mean it warrants longer therapy. So what the Infectious Disease Society of America guidance currently suggests is if you have a patient with Stenotrophomonas, you believe it's a severe infection, cefiderocol or the combination of ceftazidime, aztreonam are considered the preferred agents. For patients where they're showing some clinical improvement, let's say it's a line infection, now they're improving, the line's been pulled, you can think about combinations of other drugs, trimsulfa, minocycline, levofloxacin. I didn't show you specific data for minocycline, levofloxacin, but unfortunately, the preclinical data we have, again, we don't have clinical trial data, but the preclinical data we have is basically as disappointing as trimsulfa. So it's not like the data for any one of these drugs looks much better. We don't know that a combination will be better than the drug alone, but this is a little bit of a Hail Mary where we know that there's not confidence in any one of these drugs by themselves. So perhaps if given in combination, they're all working differently, maybe there's some chance we'll see more activity. So again, I think that for patients who are critically ill, I would say heme malignancy patients, patients in the ICU who are really not doing so well, I do think cefiderocol or ceftazidime aztreonam are preferred. And we, in our own hospital, sort of stratify patients based on how sick they are or not to kind of make this decision. But for other infections, you might want to think about a combination. Or if the patient's truly improving, perhaps trying one of these drugs by themselves to limit toxicities and slowly monitoring the patients. And I put that in not because I have good data saying that's fine, but most patients who are recovering pretty well with Stenotrophomonas are not neutropenic like those animal models, right? So maybe with the patient's own immune system in a single drug, there's times the trimsulfa by itself will be okay. I think all of us would argue, well, I use trimsulfa all the time for steno. Patients often do well. Again, a lot of times with those patients, we don't always know if it was colonization or not. They might have been more of a sort of source control issue where it's on the line's been pulled. Or it might be they have very good immune system. So the immune system in one drug alone was sufficient. So it's not to say that we always have to use these other the traditional drugs we use in combination. But it's kind of important to kind of think of this on a case-by-case basis. And again, if somebody is truly ill or truly immunocompromised, I would personally favor one of these newer drugs. So, Wasim, would you rather me stop or do Pseudomonas?
I think maybe if we can do a few minutes on Pseudomonas, and then we can just go from there. So probably in 5 minutes, if
Okay,
it's
I'll do
possible.
5 minutes of Pseudomonas.
Okay.
The brief things I want to mention with Pseudomonas is there's this term difficult to treat resistance, which I still find to be a little strange. The reason this is the case is that so what this means is Pseudomonas resistant to all of our traditional beta-lactams and quinolones. The reason this is an issue is that unlike carbapenem-resistant Enterobacterales, so for example, carbapenem-resistant E. coli, you expect that E. coli is going to be resistant to all beta-lactams, ceftriaxone, cefepime, piptazo, etc. With Pseudomonas, you might see that it's resistant to meropenem, but still susceptible to one of these other beta-lactams. That actually happens about half the time. And the reason is there is a porin on the bacterial outer membrane that's very specific for the carbapenem. So if that porin is not being produced, it can block meropenem from entering, but piptazo or cefepime could still enter. And usually we say if that's the case, we would give a high dose, maybe extended infusion beta-lactam like the cefepime, and the patient, and that's probably fine for the patient. So something to keep in mind, and usually in those cases, I do often consider repeating the susceptibilities. Okay, so this is a 12-year-old boy, very bad Pseudomonas infection in the lungs, very sick. The only antibiotic it's susceptible to is colistin. What I briefly want to mention with colistin is for colistin, we have intermediate or resistant breakpoints for Pseudomonas, Enterobacterales and Acinetobacter, we don't have susceptible. So just because you see an I here and an R for a lot of these other drugs doesn't mean it's a better drug. Colistin is administered as a prodrug that's completely inactive. And usually in patients with normal functioning kidneys, less than 5% of the prodrug gets converted to the active form. So that little amount that gets converted to the active form is very unlikely to hang around them in the bloodstream very long or the lungs very long, basically making it ineffective for treating gram-negative infections outside of the urinary tract. So colistin has really fallen out of favor. There are 4 drugs that are currently available. I'll go through this very quickly. Ceftoltazo, ceftazabine, cefiderocol, which you heard about already, and imipenem relibactam, which all have the potential to be active against Pseudomonas. And again, difficult to treat. I mean, it's resistant to all our traditional beta-lactams. There are no clinical trials or planned clinical trials comparing these new drugs to each other. We're basically left comparing each drug to usually colistin. Again, obviously, colistin's not a great drug. I will mention that all of the beta-lactamase inhibitors, again, ceftoltazo, ceftazabine, imirelli, have similar survival, but they seem to do a lot better than cefiderocol. And this is the cefiderocol is derived from a subgroup analysis of a clinical trial limited to patients with bad Pseudomonas, drug-resistant Pseudomonas, randomized to cefiderocol or colistin. So it's currently any of these 3 beta-lactamase inhibitors are considered preferred against Pseudomonas. It's recommended that if you have a carbapenem-resistant Pseudomonas, or let's say a difficult to treat resistant Pseudomonas, you test all 4 of these drugs if possible, because it's hard to know which one might actually be active. The one thing I want to point out that's very important is that, so this is a small study we did that was repeated at the University of Pittsburgh with similar results, where basically we had 28 consecutive patients with D-tier Pseudomonas infections. Their first isolate, so their index isolate of Pseudomonas, was susceptible to the drug ceftoltazo. They received the drug as a treatment course for a median duration of 10 days. And for all of these patients, we had a subsequent Pseudomonas isolate available within 30 days. So we specifically enrolled patients where we had an index and subsequent isolate of Pseudomonas. And what we found was for half the isolates, so 14 of 28 patients, the subsequent Pseudomonas isolate that was obtained from the patient within 30 days was no longer susceptible to ceftolozane tazobactam. And I'll tell you why in a second. And shockingly, even though these patients never received the drug ceftazidime avibactam, for 86% of Pseudomonas isolates initially susceptible to this drug, there was enough cross-resistance where their subsequent Pseudomonas isolate was now resistant to ceftazabine. And for a quarter of isolates, there was an increase in MICs, even if not frankly resistant to cefiderocol. So all 3 of these drugs are cephalosporin-based. Unfortunately, they're very structurally similar. So what this tells us is that even if you use a drug like ceftoltazo, ceftazabine, cefiderocol as your treatment for a DTR Pseudomonas, if that patient comes back and is quite ill, you really do want to retest susceptibilities because there's unfortunately a high likelihood of emergence of resistance. And unfortunately, this does not appear to be the case for imipenem relibactam, the 4th anti-pseudomonal drug that I mentioned. There does not seem to be is not cross resistance. And again, this study was, even though this is very small, it was repeated at the University of Pittsburgh with very similar results, just suggesting that we do need to beware of 3 of the 4 anti-pseudomonal newer drugs having cross resistance. I'm going to skip the reasons why this happens for the sake of time. The last thing I'll end with, coming back to our patient with bad pneumonia, unfortunately, his Pseudomonas isolate was resistant to ceftazabine, ceftoltazo, and imirelli, susceptible to cefiderocol. The reason was it was found to be producing a VIM, having a VIM gene. So VIM is a type of metallobeta-lactamase. It's a cousin of NDM. It's very unusual to find these in the United States, but it's a huge problem in Latin America. These are data in 2019, where 20% of their carbapenem-resistant Pseudomonas produce these enzymes. This percent has now increased to about 50%. So it's really only a matter of time before this becomes a much bigger problem in the US. And these MBL-producing Pseudomonas are never going to be susceptible to ceftol, tazo, ceftazab, imurelli, only leaving cefiderocol as an option. And if you recall, a year or two ago, there was an outbreak of contaminated eye drops in the United States, and that was because the Pseudomonas isolate in the eye drop had one of these VIM-producing enzymes, which again is a metallo-beta-lactamase. Okay, so all I'll say with DTR Pseudomonas is, unlike KPC producers or ESBL producers or stenotrophomonas, where you can often predict which of the newer drugs will be active, they're more likely to be active or not. With Pseudomonas, it's tricky, and I really would encourage testing of all 4 of the new drugs. And if that patient comes back to retest because resistance might have occurred, or there's a much higher likelihood of resistance emerging than for other bacteria and antibiotic combinations. And if you see a Pseudomonas resistant to all of the beta-lactamase inhibitors, so these 3 up here, there should be a hint that perhaps this is a metallo-beta-lactamase producing Pseudomonas. Okay, so I'll stop there. Thank you all for your attention, and I'll see if there's time for any questions.
Yeah, thank you so much. This is a great review. I just have a question that comes up, pretty frequently, and obviously it would be helpful for, the hospital medicine, the ED physicians, and also outpatient pediatricians when they're seeing those results. And it's specifically related to ESBL producing Enterobacterialis and UTIs. Obviously, one of the situations is that when this organism is also resistant to trimsulfa and ciprofloxacin, and the challenge of, admitting the patient, putting them on IV antibiotic versus giving them 1 dose of aminoglycoside, and trying to decide who is the right candidate to just get the 1 dose of aminoglycoside that is mentioned in the guidance. Obviously, we know that it has to be, patients with simple UTI, but that's not always easy to to define. So what is your experience in terms of recommendations in situations like that, for a common situation, in the ED or, outpatient, the outpatient world?
Yeah, no, thank you so much for that question. So, I think that I like to distinguish UTIs as sort of cystitis, pilocystitis, meaning, again, not febrile, not having rigors, generally well appearing, often seen in outpatient clinics, sometimes in the ED. The good news is for ESBL producing E. coli, nitrofurantoin as an oral option is very likely to be active over 90% of the time. So nitrofurantoin is a consideration. Trimsulfa, you might start it, but it may or may not be active. And luckily, Trimsulfa or Bactrim concentrates very well in the urine, just like drugs like ciprofloxacin. So even though these drugs may or may not actually test susceptible, if you're trying to avoid hospitalization for that patient, it might be reasonable to try. Remember, only about 1 in 40 people with cystitis progress to pyelonephritis if not treated. So it's possible no treatment with just hydration, the patient will get better. But if you're trying to avoid having to send them to the ED, you might think about nitrofurantoin, which I think is a good choice. Personally, I'd probably go with that, or Trimsulfa or Cipro. If they're in the ED already, and they have a history of ESBL, so this is probably an ESBL, even if you don't have your results back yet, and they're coming with, dysuria, etc., you could consider a single IV dose of, like you said, an aminoglycoside. There's not clinical trial data per se, but there is a meta-analysis putting together a lot of studies, sort of collateral evidence, and we know aminoglycosides get in the kidneys because that's why they cause nephrotoxicity. That there are data that seem to suggest a single dose of an aminoglycoside can clear the urine quite well. So if that patient's already in the ED, I might suggest a dose of an aminoglycoside. If for some reason you're worried about the kidneys because the patient has, an elevated creatinine clearance or something, like a lower creatinine clearance or something like that, you could maybe try something like a single dose of ertapenem to kind of get in that urine and then send them home with something like a nitrofurantoinol. Even if I would say they're maybe just low-grade fever, they're not quite sick enough to hospitalize, maybe there's a little bit of pyelo, but they're not sick enough to hospitalize. This is not sort of, we don't have evidence to say this will work or not work. But I do think if you're able to kind of avoid hospitalization for someone who otherwise may not need it, I do think it's reasonable to try treatments like that, giving a dose of an aminoglycoside or ertapenem and then transitioning to oral, and then just giving the patient really clear instructions when to come back to medical care if symptoms aren't improving. But obviously, if they're rigoring and like the patient in the case, that's the patient I would start on a drug like meropenem or imipenem because you don't know yet if it's going to be Pseudomonas or ESBL producing E. coli. Once you know, either transitioning to ertapenem, or if you're lucky enough to have drugs like ciprofloxacin that are active, considering switching to those. So that's generally the approach I would suggest. But thanks for bringing that up
Yeah.
because it is a very common problem.
Yeah. No, thank you so much. I think we did go a little bit over time, so for the sake of time, we're just gonna close out now. Thank you so much for, obviously talking about one of our favorite topics in infectious diseases, but also, the awareness around this for any practitioner, as we continue to see and deal with, problems with antibiotic resistance. Thank you.
Thanks so much. And if anyone ever has patient-specific questions and I can help, you can contact Wasim. He knows how to reach out
Yeah,
to me. I'm
absolutely.
happy to discuss.
All right.
Take care.
All
Thank
right.
you.
Take care. Thank you.